Assalamu alaikum. So please, let's make it an open discussion. So step in, ask a question, please, and let me know if anything you want to clarify or anything, okay? So it's like a group discussion, table discussion, friendly discussion. So please, just you can open your mic, ask, and communicate. So it will be a more interactive session. So let's start with case 1. So a 61-year-old male who is fit, previously untreated, just came with symptoms of back pain. You've done your workup, diagnose him with a multiple myeloma, and you find him that he has a high risk with translocation 414, and he had 17p deletion. So the question will be, what should be the treatment goal for this patient? So anyone want to answer or want to step in? Or should I just proceed? Okay. So I think Dr. Amr Hanbali has told you that your goal of therapy for those patients to achieve at least a very good partial response or better CRY, because this is clearly has a role in overall survival. So if you reach at least very good partial response compared to less than partial response, you have lower overall survival. And if we are able to achieve CR, you're even overall survival improved. However, in all guidelines, including our guidelines, to go to stem cell transplantation, partial response or more is enough to go for stem cell transplantation. Some center, their own guideline is to achieve at least very good partial response because that correlate with overall survival and improve outcome of the patient. So why sometimes we do PET scan? It's if you, after your first line of or induction therapy or transplant, you achieve PET negative, you have doubling time of median overall survival. So 90 months comparing to 50 months for those patients with PET positive. So the deeper the response, the better the outcome of the transplant, the better the overall survival. And this clearly correlates with the patient outcome. So for I think for at least you aim for partial response, but you should aim for very good partial response for those patients. So what would you start? Would you start this patient treatment immediately? Would you delay? Anyone want to answer? Anyone think? So in a patient with a multiple myeloma, should we wait or not? Should we start therapy or not? Okay, so I think, so all patients, once you diagnose multiple myeloma, you should start an immediate therapy. Why? Because that correlates with their outcome. And the more you delay, risk of end organ damage, renal failure, and everything. And there is a study for patients with renal failure comparing VD to VCD for this patient. So the more therapy did not give any improvement on the outcome. The improvement is how soon you started your therapy. So for VCD or VD, no difference if you add cyclophosphamide or not. The difference is how immediate you start your therapy. So the faster, the less risk of end organ damage, especially in patients with renal impairment. What would your management strategy? So what do you think? What should we go for? Induction, followed by transplant? Should you give consolidation? Should you give not? Maintenance? How long? So all we will discuss it later. Should we delay transplant, upfront to transplant? And the next question is, which do you think is the ideal induction regimen? So Dr. Hanbali has talked about doublet versus triplet, monoclonal antibody-based combination. So I think you clearly now all study, all guideline doublet is not an option, especially in patients with those high risk triplet. I think at least you should give triplet, monoclonal antibody based combination versus not. So you've seen with Dr. Amr Hanbali that his MSMART, that 2020 MSMART showed if you have double hit or triple hit, you should think about adding monoclonal antibody for those patients. Based on what? Based on Alcyon trial, based on the VMB data. However, for VRD, we still not. So the Griffin, we're waiting for more of the Griffin protocol. So why now everyone is VRD induction? This is based on the SWOG, showed better response and very good partial response. And we know if you achieve more very good partial response, that correlate more with overall survival. And this is the PFS and the overall survival for those patients. Now, everyone talk about VCD versus VRD. So I have a slight like different opinion with Dr. Hanbali, which should we give VCD or VRD? This is based on just our own way of diagnosis. So at King Faisal, they don't do plasma cell purified cytogenetics or FISH. So they just do it for all the bone marrow cells, which is less accurate and does not give you an exact high-risk patient. In addition, we are unable to do 1Q amplification for those patients. So we might miss some of those patients. So personal opinion, I think VRD at least should be your aim of therapy, at least for those high-risk patients. So I'm going to give you 3 studies that compare VCD to VRD. So this is in patients with multiple myeloma at Mayo Clinic. They retrospect analysis of their pooled data they have. So they have 88 patient VCD, 71 VRD. Despite more VCD patients have renal failure, the response rate was the same. 1 year, 2 year PFS, 1 year, 2 year overall survival is the same. However, this is a pooled analysis, not direct comparison. And for those patients, it showed, you see, this is overall survival is the same for those both patients. Another study from Europe, they have 68 patient retrospective analysis. They showed better overall response in VRD comparing to VCD. Overall response for non-transplant for the VRD is even much higher, 20% different almost. They showed 1.5 year PFS is better with VRD, and even overall survival at 18 months is better with VRD. So this is another study that moved toward VRD for induction. I know both of them are retrospective analysis of pooled data. So the only randomized study that was published last year, it's like the number was not high, but at least it's a randomized trial. They did not report PFS or overall survival. However, they have very good partial response is higher, and CR is even double with patient with VRD and VCD. So I think high risk patient, they should receive at least VRD. Standard risk, I am more in favor of VRD because of our setup. Like we cannot diagnose proper high-risk patient. And there is a clearly data indicate IMiDs is better than cyclophosphamide, like from the KCD, KRD comparing to KCD, and VTD compared to VCD. So this is also retrospective analysis showed better response in patients with VTD compared to VCD. And this is the IFM that was Dr. Amr Hanbali told us about. It's also better response. So we have more and more data that's IMiDs in combination with proteasome inhibitor is better than alkylating agent like cyclophosphamide from one randomized study, from one large retrospective study, and from KCD and KRD, the carfilzomib Revlimid Dix comparing to carfilzomib cyclodix from the British group. And this is also from the IFM, the French one. VTD is better response than BCD. So for the induction, let's talk. Anyone has any question about what should be induction regimen, VRD, VCD, VTD? I personally don't like thalidomide because tolerability for the patient is poor with thalidomide, side effect is more. VRD, we have a good response for those patients. The problem with VCD and VRD is just the cost. High-risk patient, should we combine antibody? So until I think we have the more data about the Griffin, even now that I'm gonna show you the Griffin 124 month should start of separation, but maybe by next year we have more data, so we know is it supported? Because if your frontline is VTD, so we clearly have VTD DARA is better than VTD alone, especially with high-risk patients. So if your induction regimen is VTD and you have a high-risk double or triple hit, I think daratumumab should be combined for this regimen because you have a clear data that support. If you have a VRD, I think you need to wait maybe one more year to see what is the 3-year PFS, if there is any overall survival benefit, or at least PFS benefit. So the question is, how many cycles? 4 versus 6, 4 versus 8. So this is a study which was published last year on blood and showed if you give 2 more cycles, like from 4 to 6, you only gain 6%. So so you just increase your response by 6% and you have more side effects. So I think that's why if you see the international recommendation, Europe, USA, they all recommend around 4 cycles for those patients, especially if you are using IMiD-based, because you don't want to reduce your stem cell collection for those patients. So now we know if you're going to use for high-risk patient induction, if you're going to use VRD, it's fair enough. However, you have the MSMART said VRD DARA for those patients, but I think we should wait 1 more year. If you use less than VRD, I think adding daratumumab is, you would have a benefit, especially if you're using VTD, because we clearly have the VTD showed if you combine DARA, you have better PFS, especially if you have for those with high-risk patients. So please, if you have any question, if you want to comment, if you want to share, stop me and ask.
Saud, I just have one comment.
Okay.
Regarding the choice of the induction therapy between like VCD, VRD. The issue is, many publications now are heading towards what's known as the real world data, comparing this to randomized trial results. It's very important for the center's experience in publishing their own real world data to comment on what's the outcome of the induction regimen they're using. I looked at some of the CIBMTR data regarding difference between VCD and VRD, and many centers, they show that they have high remission rate with the VCD regimen. Also, we looked at our own data in King Faisal. VCD also produced a good high remission rate. As you mentioned, it's because maybe we don't do the cytogenetics properly, and it's very hard to stratify in a good way. Still, I believe in the real world data. So, and we have just to make sure that it's not just go and adopt what's published in randomized trials. You have to have your own experience and your own data, okay?
Okay, so it's a point. So another perspective is like the real world data, your own outcome. So always with any type of disease, myeloma, leukemia, anything, it's better that every 3 or 5 years you go and look into your own data. Is it comparable? Are you doing good? Are you doing better than what has been published? Are you doing worse? What is the reason? So if you're doing better, maybe your patient has less advanced disease, less a poor cytogenetic. If you're doing worse, is your patient presented with an advanced disease? So it's better you retrospectively analyze your data and you see how's your outcome. So what do you think if the patient had suboptimal response to induction? So always, if you have suboptimal response, you need at least less than partial response, you have to switch. So I have a recent, like a patient who she wants to be treated same as US wave. She's very educated. She even gave me more the data and the recommendation, the Mayo Clinic and everything. So we agreed to start her on Mayo Clinic. She even asked about to be the same as the SWOG 777. So she wants 1, 4, 8, and 11, not the weekly one. However, she had suboptimal even to VRD response. So what is your option? Anyone want to comment? So I think switching to another regimen or adding is the option. So if the patient in VCD, our own protocol is to shift to VRD. However, if the patient in VRD, I think one option, so continue Revlimid, maybe will harm your stem cell collection, so maybe switching. So one option will be adding DARA, like you give VCD with DARA, or you give more 2 cycles with DARA, or you switch to carfilzomib, cyclophosphamide, dexamethasone. So this is one option for those patients. So we know this is the Griffin we're talking about. So you see, you have a diver response with DARA VRD. So the CR is higher, 80% comparing to almost 50% at clinical cutoff. However, we still, so here you see at 24 months, the curves start to separate. However, we need more time to see if there is any PFS or overall response benefit for those patients. However, if other induction, you can clearly add DARA. So I think switch those patients on VCD, you can clearly move to VRD. Those already on VRD, you can add DARA. You can switch to carfilzomib, cyclophosphamide. Dex, you can give VCD DARA, VRD DARA for additional 2 cycles. Maybe you have some problem with mobilization, but you have to achieve at least partial response to go for a transplant for those patients. Other option, if patient is like severely heavily disease and extramedullary, maybe you think of VTD pace induction, and you collect with the second cycle. So there are many options. So option 1, adding antibodies, monoclonal antibody like daratumumab. Option 2, you switch to carfilzomib, cyclophosphamide, dex. Option 3, if the patient is extensive disease, extramedullary, is you switch to VRD pace and you go for an auto transplant after second cycle. Are there any circumstances which you delay transplant? I think I wouldn't delay transplant unless patient has suboptimal response. You know, even the M-SMART recommendation is to go for an upfront transplant, even preferred for standard risk patients. So especially with high risk, I wouldn't delay, because those patients, if you miss the boat or patients start to progress, will be difficult to put them into remission again for those patients. Which mobilization regimen should we use? So you can mobilize them with the GCSF alone or cyclo-GCSF. We use cyclo-GCSF because clearly study showed you have a higher response and higher CD34 count if you use GCSF with cyclophosphamide in those patients. Sometimes we need to use plerixafor in a patient who had multiple cycles of therapy. Data from monoclonal antibodies showed maybe there is a trend to use more plerixafor for those patients. However, adding monoclonal antibody did not interfere with CD34 collection. 1 or 2 transplant. So this is always an issue. So if you are on 1 transplant, people they use their stamina trial as their argument. If you on double transplant, they use the European. I'm going to show you. So this is the stamina 250 in each arm, very large, well-randomized trial. However, patients with high risk, they are low on those patients, and group analysis did not conclude any benefit. So if you see auto consolidation, auto maintenance, however, those more and more on this stamina, they have some standard risk. So you can still argue that it's one transplant. However, Michel Cavo reported for those patients with high risk, double transplant should improve their outcome and survival by 40% if you receive tandem transplant in 2013, and the follow-up in 2017 at ASH, it showed clearly benefit for PFS and overall survival on those patients, single versus tandem transplant in high risk, because this one has higher representation of high risk on those populations. So high risk always it showed it's an option. So I know in Canada at Princess Margaret, they retrospectively, so their guideline was to go for tandem transplant for any high risk. They retrospectively, they showed tandem did not improve the outcome. However, I think still an option based on this data for those patients. What about Rick Allo? So I think maybe Dr. Amr Hanbali can also support. So allo transplant is not a good option. So based on, he had 3 patients who had an allo transplant. I have recently patient who had an allo transplant. Basically, there is no good GVL. You ending up, my patient grade 4 GVHD. What do you think, Dr. Hanbali, about allo transplant? So.
From personal experience and from also what published data, it looks like toxicity is high with allogenic transplant in multiple myeloma. Myeloablative used to have like 40% transplant-related mortality. With reduced intensity, of course, that's less, but still, what we noticed, the GVHD is more severe in myeloma patients. So, and the most common cause of failure in allogenic transplant in myeloma is actually relapse. So, as you mentioned, the myeloma, or graft versus myeloma effect is weak. And so far, what you're going to end up with severe toxicity, with a very bad GVHD, and at the same time, the patient will relapse. So it's not recommended as upfront therapy in any guidelines right now. There are clinical trials that are looking at this, but outside clinical trials should not be used in the upfront therapy for whatever reason.
Yeah, and recently I have a discussion with Dr. Usmani, from North Carolina. He said they stopped using it, especially now with the CAR T cell therapy. At my clinic, they have a huge number of myeloma patients, and they're only doing, like they said, 5 to 6 per year. So I think even at Canada, they did 5, 3 they had like transplant-related mortality. 2 they progressed, so they did not see any good outcome with an allo transplant. I think the last 3 years we did 5. None of them survived longer with those patients. Some of them with GVHD, severe GVHD. So post-transplant consolidation. So I think for high risk, maybe I would consider consolidation. Standard risk, no, based on the stamina trial. So standard risk, induction, transplant, maintenance, high risk, induction, questionable tandem transplant. If the patient agreed, consolidation 2 cycle, then we'll go for maintenance. Would you consider maintenance treatment for this patient? Yes. So high risk patient, all recommendation is bortezomib based. So bortezomib based does not mean only bortezomib. You can combine it with Revlimid. You can combine it with Revlimid and Dix, like VRD for those patients. And I think the maintenance talk about at least 2 years. However, I preferred with a high risk until disease progression for those patients. So the study showed VRD induction, tandem transplant, VRD consolidation and maintenance. They should comparable outcome to the patient with a standard risk. However, so I personally think if you have an ultra high risk, you should give at least Velcade, Revlimid for those as maintenance. We know Revlimid alone in a high risk did not show any benefit for high risk, so that's why. And the proteasome is based on the HOVON study. For those patients showed, especially with translocation 414, those patients have some benefit from proteasome inhibitor. So if the patient has a standard risk, I would say the same. As I said, VRD or VCD induction, transplant, and go to maintenance, no consolidation, no tandem transplant. If the patient has extramedullary disease, an aggressive extramedullary, I think I would go straight forward for VRD or VTD PACE treatment. I have a patient with an extramedullary disease, aggressive extramedullary, the one who went into the allo. I tried to use KDD, like carfilzomib, Dara, Dix for induction, did not work. So those with an aggressive disease, I think you should give some chemotherapy to those patients. So the only thing that gave him into partial response was the VRD PACE treatment. I think those extramedullary, they behave, Dr. Walid Rashid used to say they are behaving like a lymphoma and they need chemotherapy, and I totally agree with him. Maybe you can use your proteasome, your antibodies as a consolidation or a maintenance for those patients, but maybe upfront some VRD or some using KRD PACE induction for those patients with an extramedullary disease. MRD assessment, unfortunately, we don't have an MRD assessment so far. It's now being moved, and it's now it showed clearly MRD negatively improve PFS and overall survival, and that's why it's approved by FDA and EMA as a surrogate endpoint for myeloma for those patients with a myeloma for almost 2 years now. That's why some of the new study, they use MRD as their endpoint negativity. So if you are an MRD, we always say if you are very good partial response, you have a good, if you have CR, you're better. If you have an MRD negative, you're even better. If you have a PET scan negative, you'll always have a better outcome. So I think for the sake of time, we'll use only one case scenario for induction for those patients. Transplant ineligible, I think Dr. Amr Hanbali has talked about, so we will stop here. So if you have, please, any question, let me know. So maybe we move to the second group if you want.
Yes, doctor, we will switch now. It takes 1 minute.
Okay.
Thank you.